So can you guys see my screen?
Yeah, everything is okay.
Well, I hope everything is okay there. I've shortened this a little bit, maybe a good thing, so to allow time for questions. But what I want to talk about today is something fairly frequent in the hospital, and unfortunately probably fairly frequent where you are, which is acute kidney injury. Defining it's fairly straightforward. What acute kidney injury means is that there's a fairly rapid decline in glomerular filtration rate. You end up with retention of waste products, and probably most importantly, perturbation of the kidney's ability to maintain homeostasis of extracellular fluid volume, electrolytes, and acid-base status. It's a fairly frequent occurrence, at least in the United States. A meta-analysis in 2013 estimated that about a fifth of hospital admissions are associated with acute renal failure or acute kidney injury, as it's now called. And more than 50% of ICU admissions are associated with some degree of acute kidney injury. It's usually reversible, assuming the individual survives their other comorbidities, and it's associated with significant mortality. If someone's in the ICU and end up with AKI severe enough to require dialysis, the mortality is approximately 50%. If you look at the hospital overall, somewhere between 15 and 30% of patients with acute kidney injury don't survive. It can complicate a wide variety of diseases, and because of that, nephrologists typically like to subdivide the causes. We classify it based on etiology. A significant proportion are caused by poor renal perfusion, what's called pre-renal AKI. A smaller percentage are caused by obstruction, and we're going to talk about each one of these categories separately. And then obviously a significant number are caused by intrinsic damage to the kidneys. And there's so many different causes of that they're also subdivided the way that you see here. Pre-renal AKI, and dinosaurs like me don't like to call pre-renal AKI, where it's not, I've always been somewhat not convinced that poor renal perfusion actually causes renal damage, although if it's severe enough, it probably can. But poor renal perfusion can certainly cause perturbations of the kidney's ability to regulate. It's typically caused by a decrease in effective intravascular volume and a decrease in renal perfusion, and can be caused by a variety of things. Obviously, volume depletion, disruption of cardiac function for the reasons you see here, and then redistribution of extracellular fluid volume caused by hypoalbuminemia, physical causes, which I'm sure you guys see a lot of, and then peripheral vasodilatation, particularly sepsis. In addition, renal vasoconstrictors can cause decreased renal perfusion. The final thing I would say is that nephrologists talk a lot about non-steroidal anti-inflammatory drugs like ibuprofen, indomethacin, and drugs of that class. If you have normal renal perfusion, if you're not volume depleted and you don't have one of these causes for decreased renal perfusion, non-steroidal anti-inflammatory drugs probably don't do much to your renal blood flow. However, if you have some reason to have poor renal perfusion, the remaining renal perfusion becomes very dependent upon prostaglandins, particularly PGE2 and PGI2, also called prostacyclin. So if you see someone who has poor renal perfusion, non-steroidal anti-inflammatory drugs can further worsen that renal perfusion. But once again, if you don't have poor renal perfusion, non-steroidals don't do much. Obstruction is an obvious way that you can cause acute kidney injury. And for obstruction to cause AKI, you either have to obstruct both ureters or you have to obstruct a single kidney. The obstruction can occur at several different levels, obviously. It can occur high up above the bladder in the renal pelvis or in the ureter, and that can be caused by things within the kidney or within the collecting system, such as clots, stones, the slough papillae, or you can get things that compress the ureters from outside, particularly malignancies, which we happen to see a lot of here because we have a cancer center. Obviously, you can obstruct the kidney at the level of the bladder, and it's somewhat easier to do that because if you obstruct the bladder, you've obviously obstructed both ureters. Once again, you can see the things here that would be likely to cause it, particularly, once again, malignancies. And then finally, anything that obstructs below the bladder at the level of the urethra can cause obstructive AKI. And then finally, intrinsic acute kidney injury is a common cause, and there are so many different causes, we tend to subdivide it into different categories. You see them here: vascular, glomerular, interstitial, and tubular causes. Vascular causes of AKI can be due to either arterial or venous obstruction. In the arterial system, that can be due to a clot, either intrinsic or embolic, or an aneurysm. Obviously, on the venous side, you can have clots or vena caval obstruction for some other reason. And then inflammatory diseases of the vasculature, vasculitis, can cause acute kidney injury. If the vascular inflammation does not involve the glomeruli, you may not see a lot of abnormalities in the urine sediment, but frequently vasculitis will involve the glomeruli. And if the glomeruli are inflamed, you'll see red blood cells in the urine and red blood cell casts. And I'll show you a picture here in a moment. Red blood cell casts are pathognomonic of glomerular inflammation. You typically have moderate to heavy proteinuria, hypertension is relatively common, and vasculitis is frequently part of a multi-system disease. We may end up biopsying something when we see someone with vasculitis. We sometimes biopsy the kidneys, but for example, if someone has a vasculitis and they have a skin rash, you may biopsy their skin rather than their kidney because a skin biopsy is much less invasive than a kidney biopsy. But it's not uncommon that we biopsy kidneys to confirm a diagnosis of vasculitis. Glomerular causes of AKI, glomerulonephritis, which is the term we use to stipulate inflammation of the glomeruli, is another cause of AKI. Once again, in this case, there may or may not be vascular inflammation. You can have glomerular inflammation in the absence of vascular inflammation. When the glomeruli are inflamed, you will typically see red blood cells and red blood cell casts in the urine. Because there's heavy proteinuria and the proteinuria may be of significant duration, you may see lipid bodies and lipid casts. The reason for that, some of the protein that's filtered in large quantities when there's glomerular inflammation are lipoproteins. One of the normal functions of the proximal tubule is to reabsorb the small amount of protein that's filtered by normal glomeruli. When you have inflammation of the glomeruli, you have larger amounts of protein spilling into the proximal lumen, and the proximal tubules try to reabsorb that material, and they're overwhelmed. As I said, some of those proteins are lipoproteins, and those lipids get incorporated into the cast, and you can see those under polarized light. Once again, there's heavy, typically moderate to heavy proteinuria. Some textbooks would say that hypertension is not universal. That's probably true, but when you have a significant disruption of kidney function, hypertension is actually pretty common because the kidneys are so intimately involved in controlling blood pressure. you may have nephrotic syndrome, meaning heavy proteinuria, low serum protein, and high cholesterol. And once again, this may be part of a systemic disease. And once again, it's quite common that we will biopsy a kidney or sometimes another tissue to diagnose glomerulonephritis. And then finally, interstitial causes of acute kidney injury sometimes cause tubular interstitial nephritis. In this case, the inflammation is occurring in the spaces between the tubules and the vascular structures within the kidney. The urine sediment typically has white cells and white blood cell casts, and I'll show you a picture in a minute. Sometimes you'll see tubular epithelial cell and tubular epithelial cell casts. If it's part of an allergic phenomenon, and you can see interstitial nephritis because of allergic phenomenon, you may actually see eosinophils in the urine. Typically, the proteinuria is only mild, and the reason for that, the glomeruli are still relatively normal when you have interstitial nephritis. And so, as I mentioned earlier, glomeruli do leak modest amounts of protein even when they're normal, and the proximal tubulars typically reabsorb that and catabolize it. When you have tubular interstitial nephritis, the proximal tubules may not perform that function well. And so the proteinuria that you're seeing reflects normal glomerular protein leak. You may or may not have hypertension with tubular interstitial nephritis. Once again, if it's part of an allergic phenomenon, you may see a rash, you may see eosinophils in the periphery, and there may be a history of a drug allergy. Sometimes we will biopsy people to diagnose interstitial nephritis, and sometimes we will biopsy people because we see acute kidney injury and we don't know why, and we'll find interstitial nephritis. But not uncommonly, we'll identify a likely culprit. You know, we'll see someone who has modest AKI, a modest amount of protein, eosinophils in their urine, and they're on a drug that's known to be a likely cause, and we'll stop the drug, and frequently it'll resolve on its own. With significant allergic interstitial nephritis, we actually do administer steroids, and we're more enthusiastic about that if we actually have biopsy-proven tubular interstitial disease. And then pure damage to the tubules, what's typically called acute tubular necrosis. In this case, the urine sediment's not quite as pathognomonic. You may see tubular epithelial cells and epithelial cell casts. Sort of the typical thing you'll see are pigmented coarse granular casts. Once again, the proteinuria is mild to moderate. They may or may not have hypertension, and a biopsy is typically not necessary to diagnose acute tubular necrosis. The reason for that, and we'll talk a little bit more about this in a few minutes, is that ATN typically occurs in certain clinical situations, and it's not difficult to identify those situations as well as why the ATN is occurring. To evaluate someone with AKI, since you guys are med students, believe it or not, a history and physical is still one of the cornerstones of trying to determine why people are sick. And that's why I'm presuming in your med school, as in every med school in the world, there's a lot of emphasis on how to take a good history and physical. In terms of relevant parts of a history that might give you clues as to why someone has AKI, anything that would cause volume depletion, nausea, vomiting, and diarrhea, things that might be associated with obstruction, if someone has a prior history of kidney stones, if someone has cloudy urine or blood in their urine, or if they have flank pain, all of those are relevant things in the history. Certain individuals with chronic diarrhea are prone to kidney stones, and those are people that malabsorb fat. People who have, for example, pancreatic insufficiency and malabsorbed fat are prone to calcium oxalate stones. The reason for that is that calcium and oxalate typically travel together in the gut and end up in your stool. When you malabsorb fat, the fat can saponify with calcium, leaving the oxalate relatively unbound, and those people can hyperabsorb oxalate, and they have large amounts of oxalate in their urine, and for that reason, they tend to form calcium oxalate stones. And so a history of chronic diarrhea, especially fatty diarrhea and fat malabsorptions, is relevant in the history. Papillary necrosis can cause obstruction. The most frequent causes or associations of papillary necrosis are diabetes, sickle cell disease, alcohol abuse, nonsteroidals, and chronic urinary tract infections. And then you always want to ask about drugs, both prescription and non-prescription drugs. I'm not sure what drugs require prescription in Ukraine, but in the United States, several non-steroidal anti-inflammatory drugs can be bought without a prescription. And when you talk to patients, they may or may not tell you about drugs that they take without a prescription unless you specifically ask about them. Things in the physical exam that may give you clues as to why someone has AKI include anything that might suggest poor renal perfusion. If someone's blood pressure drops when they stand up, if they have edema, if they have signs of congestive heart failure, if they have physical findings of chronic liver disease, and obviously if they're acutely infected. In children, you may actually be able to assess kidney size. It's difficult to do in adults, and especially in the United States, where obesity is fairly rampant. Trying to assess kidney size by physical exam is difficult, but you can always look for flank tenderness by physical exam. You can try to assess bladder size, either by palpation or percussion. And in the United States, we have small ultrasound probes that will allow us to assess bladder size. In men, you may want to do a rectal exam to see if they have an enlarged prostate, and examine their external genitalia. And in females, if you're going to be complete, you may want to do a pelvic exam to look for abnormalities in the pelvic anatomy. We like to do non-invasive things because obviously they're not invasive, and many of them are quite cheap. Simply assessing urine volume. If someone is absolutely positively anuric, meaning they're making no urine, which is defined as less than 100 milliliters per day, you want to have a high index of suspicion for obstruction, either of the ureters or the bladder. Occasionally you see bilateral vascular occlusion. It's somewhat unusual with glomerulonephritis to see absolute anuria. If someone has had severe renal hypoperfusion and some other insult, sepsis, vasoconstrictors, sometimes you'll actually get cortical necrosis, meaning necrosis of the glomeruli, and you'll have anuria. That's relatively unusual. One of the things that I've seen once in my career is alternating anuria and polyuria. And you see that with obstruction. The idea is that you obstruct the collecting system, the pressure builds up behind that obstruction, and it gets high enough to blow up in the obstruction. And you see this burst of urine, and then you relieve the pressure and the obstruction recurs. That's pretty unusual. But if you see it, it's something that might make you think of obstruction. And then probably the most common thing we'll see is low urine volumes, what's called oliguria, defined as less than about 400 or 500 milliliters per day. And this can be caused for a variety of reasons, but particularly by poor renal perfusion or acute tubular necrosis. The definition of oliguria is not arbitrary. The idea that oliguria is less than 400 to 500 milliliters per day has to do with the fact that a normal non-hypercatabolic individual will generate about 600 milliosmoles of obligatory waste products per day. A healthy young human, like you medical students, can probably generate a urine osmolality of about 1,200 milliosmoles per kilogram in their urine. So if you're generating about 600 milliosmoles of waste product per day, and you can generate a urine osmolality of 1,200 milliosmoles per kilogram, that means the smallest amount of urine that you can generate and excrete your obligatory waste products is about 500 mils per day. The sort of the thing that we ignore when we're talking about that is that if someone's sick, they may generate more than 600 milliosmoles per kilo of waste product per day. And in addition, they may or may not be able to generate a urine osmolality of 1,200 milliosmoles per kilo. But you have to sort of draw the line somewhere, and that's where the line's drawn, and that's the reason why. Urine electrolytes and urine creatinine can be extremely useful in trying to especially distinguish states of oliguria. My guess is you may have been taught this in your renal physiology class. I don't know, but you can actually calculate the fractional excretion of anything that's in the urine. We're particularly interested in what's called the fractional excretion of sodium. The equation is down there at the bottom for the fractional excretion of whatever. Basically, what fractional excretion is comparing how a solute, for example, sodium, is handled in comparison to creatinine. If you look at the urine plasma creatinine ratio, that's elevated because as glomerular filtrate travels through the nephron, water is reabsorbed. We assume that creatinine's neither secreted nor reabsorbed, which isn't quite true, but we ignore that. And so urine creatinine is almost always higher than plasma creatinine because of extraction of water. If the compound you're looking at, compound Z, is treated just like creatinine, it'll have a fractional excretion of 100%. Now, most things have a fractional excretion much lower than that. For obviously, one of the major functions of the tubules is to reabsorb solute, particularly electrolytes that are filtered by the glomerulus. One of those electrolytes is sodium. If someone is volume depleted, or if they have another reason to have poor renal perfusion, the kidneys typically avidly reabsorb sodium, and you'll have a fractional excretion of sodium that's low, typically less than 1%. If the kidneys are actually damaged in their ability to reabsorb sodium, and you have oliguria because of tubular injury, you'll typically see a fractional excretion of sodium of greater than 1. Now, obviously, we use diuretics frequently to encourage the kidneys to excrete sodium, and so it becomes difficult to interpret the fractional excretion of sodium in someone who's on a diuretic. People have looked at other things to try and distinguish between pre-renal causes of oliguria and intrinsic damage causing oliguria. One that's become popular is the fractional excretion of urea. There's nothing magical about the number 35%. It just so happened that if you clinically look at patients that are pre-renal, they typically will have a fractional excretion of urea of less than 35. Those with intrinsic renal damage will typically have a fractional excretion of urea greater than 35. Similarly, with fractional excretion of sodium, the 1% number, there's nothing magical about that. That just happened to be the number that best distinguished between poor renal perfusion and intrinsic renal damage. And then finally, in terms of non-invasive things, a simple urinalysis can give you a lot of information. It'll tell you specific gravity. It may tell you urine osmolality. You can see if there are red blood cells or red blood cell casts. And once again, red blood cell casts are pathognomonic of glomerular inflammation. You may see white blood cells or white blood cell casts. If you see white blood cell casts, that's pathognomonic of tubular interstitial disease. And you may see brown muddy granular casts, which are typically seen with acute tubular necrosis. You can also see other things in the urine, like crystals. If you see lots of uric acid crystals in someone with cancer, it makes you think about tumor lysis syndrome. People with cancer and large tumor burdens will sometimes spontaneously have necrosis of their tumors and generate uric acid. But particularly people with large tumor burdens who get chemotherapy to treat their cancer will release a lot of uric acid, which will frequently damage the kidney. And then you can sometimes see calcium oxalate crystals in the urine. Once again, people who malabsorb fat may have a lot of oxalate in their urine. In the United States, sometimes people will become poisoned either intentionally or accidentally with ethylene glycol, which we use for antifreeze in the United States. Ethylene glycol is metabolized to oxalate, and people who ingest ethylene glycol will have a lot of calcium oxalate crystals in their urine. And in terms of things that you will see in the urine, these pictures on the left are what are known as dysmorphic red cells. The idea, these are red cells that have been squeezed through an inflamed glomerulus and don't look normal. And then on the right, you see a pathognomonic red blood cell cast. Hopefully you can see my pointer. You see this cast, which is in the shape of a tubular lumen. You see the cells, and the cells do not have nuclei. This is a pathognomonic red blood cell cast and is indicative of glomerular inflammation. These are white blood cell casts. Once again, a cast in the shape of the tubular lumen, and you can see the cells, and they have nuclei. These are white cells in a cast, and they're pathognomonic for tubular interstitial inflammation. It doesn't tell you why there's tubular interstitial inflammation. It could be due to infectious pyelonephritis. It could be due to an infection, or it could be due to an allergic phenomenon if there's an agent known to cause allergic interstitial disease. These are brown, muddy, granular casts, which you'll typically see in someone with acute tubular necrosis. These are epithelial cell casts. And then finally, things that we use to try and evaluate acute kidney injury are radiologic studies. Probably the most common is ultrasound. Ultrasound machines are readily available. They're, at least in the United States, they're available in every hospital in the country, regardless of how large or small. It's very non-invasive. You could actually come to the bedside and do an ultrasound in someone who's unstable. It'll tell you kidney size. It'll tell you how echogenic the cortex is. And the reason why that's of interest, normal kidney cortex is not terribly echogenic. It's typically less or at most about as echogenic as liver or spleen. With chronic kidney disease, you typically get progressive fibrosis of the kidney, and fibrotic kidney tissue is more echogenic than normal kidney tissue. And you can see that on an ultrasound. An ultrasound will allow you to assess the collecting system if you're concerned about obstruction. You can see kidney stones on an ultrasound, even non-radiopaque kidney stones. You can assess the bladder. Once again, it's non-invasive and readily available. Occasionally, we'll use radionuclide scans. With a radionuclide scan, the radiologist radio-label a substance that's typically filtered and or secreted by the proximal tubular or both. It'll tell you about relative renal blood flow of both kidneys. It'll tell you about tubular viability, and you can also use it to assess for obstruction, probably not used as commonly as sonography. Occasionally, if you don't have access to a sono, you can do just a regular X-ray of the abdomen, what we call a KUB, standing for kidneys, ureter, and bladder. Occasionally, you can assess renal size, although it can be difficult in people that are obese and if there's a lot of stool. If someone has stones that are radio opaque, you'll see that you can see them on an abdominal film, and you can also see calcifications in the kidney. But an abdominal X-ray probably is not the first thing we choose. On very rare occasions, we will administer IV contrast in people with acute kidney injury, and it's usually if we have a strong suspicion that there may be some sort of vascular issue, either arterial or venous. And we want to actually assess the patency of the vasculature, or, for example, look for a dissection of the aorta. It's unusual unless we have a real high suspicion for something like that. And the reason why IV contrast that's used for these type of studies is nephrotoxic. And so we typically try to avoid contrast unless there are specific situations that make it necessary. What causes acute kidney injury? Well, almost half are caused by acute tubular necrosis. About a fifth are due to pre-renal causes, anything that causes poor renal perfusion. I would emphasize that someone who has poor renal perfusion, that doesn't tell you anything about their volume status. You have to assess their volume status by physical exam. They may actually be volume depleted, or they may have some other reason to have poor renal perfusion, such as congestive heart failure or chronic liver disease. A smaller percentage have acute on chronic disease, about 10% are obstructive, and then smaller percentages have glomerulonephritis, interstitial nephritis, or perhaps atherosclerotic disease. Acute tubular necrosis, since it causes nearly half of cases of AKI, we typically subdivide that into ischemic and nephrotoxic causes. Ischemic ATN is typically caused by poor renal perfusion plus another insult. If you simply have poor renal perfusion, that's usually not enough to cause ATN. It's usually there's another insult. You have poor renal perfusion because of sepsis, and we put you on vasoconstrictors to support your blood pressure. You have poor renal perfusion, and the ER does a CT with contrast, and you get contrast-induced renal injury. You have poor renal perfusion, and someone gives you a non-steroidal anti-inflammatory drug. In that case, you have to remember that non-steroidals can also be causes of acute interstitial nephritis. But ischemic ATN is fairly common, especially in the ICU, where we use pressors fairly frequently to support people's blood pressure. And then there are obviously many nephrotoxic causes of ATN. Antibiotics are a common cause, aminoglycosides, amphotericin B. You got to remember that antibiotics can also cause allergic interstitial nephritis, particularly penicillins, sulfa drugs, and fluoroquinolones. Radiocontrast is a frequent cause of nephrotoxic ATN. Certain chemotherapeutic agents can cause it. Globin pigments can cause nephrotoxic ATN, and unfortunately, you're probably seeing more of this than we do because of crush injuries suffered in the war. Certain solvents and other toxins can cause ATN, and they're on rare occasions anesthetics or heavy metals. Those are pretty unusual. What's the typical clinical course of acute tubular necrosis? If it's severe enough, they'll typically be in a period of oliguria, which may be of variable duration. You can see non-oliguric ATN probably more commonly with nephrotoxic ATN than ischemic ATN, and it probably indicates a less severe injury to the tubules. The oliguric phase may be followed by what's sometimes called a diuretic phase. I don't particularly like that name. What the so-called diuretic phase represents is when there's no, typically the oliguric phase is caused by severe injury and sloughing of tubular epithelial cells into the lumen of the tubules and a sort of microobstruction. The diuretic phase is when you reestablish some degree of tubular flow, but there's impaired ability of the kidney to regulate urine flow. And because of that, during the so-called diuretic phase, patients can't regulate their volume status, and they may become volume depleted if we don't pay attention. And then typically, ATN's followed by a period of recovery. Many times recovery from ATN doesn't occur until the other aspects of the acute illness have resolved. And it's said that you may continue to have some degree of recovery from ATN for up to a year. Obviously, we're more encouraged that there will be more complete recovery if we see recovery early. You know, if you're 3 to 4 months after an episode of ATN and you still haven't seen much recovery, you're not going to be very optimistic that you're going to have recovery at all. Management of acute kidney injury, the best way to manage it is to prevent it. Effective fluid and electrolyte management, don't let people get volume depleted. Keep their volume status appropriate. Use nephrotoxic agents carefully, non-steroidals especially. But if you're using a nephrotoxic drug such as an antibiotic, you want to monitor their renal function closely. And if you're using an antibiotic in which we monitor drug levels, monitor the levels and respond appropriately. On occasion, when we see the beginnings of acute kidney injury, we'll attempt what's used to be known as early reversible or early reversal. What you would do is aggressively hydrate these people and then give them a trial of a loop diuretic. You only want to do that after they've been well hydrated. You don't want to give a loop diuretic to someone who's already volume depleted. Whether or not you can reverse acute kidney injury, I think is a matter of contention. You may at least be able to reverse the oliguria, and non-oliguric acute kidney injury is easier to manage than oliguric AKI. As I mentioned, radiocontrast is a fairly frequent cause of acute kidney injury, and because of that, it probably is worth special mentioning. There are certain risk factors that make radiocontrast-induced acute kidney injury more likely. If someone has pre-existing renal insufficiency, if they have diabetic nephropathy, if they have volume depletion or other causes for renal perfusion, especially chronic liver disease. People with chronic liver disease are particularly prone to radiocontrast-induced acute kidney injury. If you have a large contrast load, and people with myeloma are particularly prone to radiocontrast-induced kidney injury. Things to try and prevent radiocontrast-induced kidney injury. Many things have been tried, and unfortunately, many things have failed. It's fairly well established that hydration is probably of some benefit. There's been a lot of debate about whether or not you should use hydration with sodium bicarbonate versus normal saline. Probably the consensus is it doesn't matter. As long as you hydrate people appropriately. You probably want to stop nonsteroidals. In the past, people have tried to use diuretics and or mannitol. Those have not been shown to be a benefit and sometimes make it worse. Limiting the contrast load is probably a benefit. Radiocontrast comes in several sort of vintages. The original radiocontrast was ionic and very hyperosmolar and was quite nephrotoxic. Second generation contrast is non-ionic but mildly hyperosmolar. And then the newer vintages are not only non-ionic, they're isosmolar, and there was a lot of enthusiasm about isosmolar contrast. But the latest studies haven't really supported that it's non-nephrotoxic and it's more expensive. So most radio contrast is of the non-ionic hyperosmolar variety. Other things have been tried. Acetylcysteine, which goes by the trade name Mucomist, is a free radical scavenger and was thought to be a benefit. There have been a whole host of studies looking at this. Some were suggestive of a benefit, others were not. It's quite cheap, it's inexpensive, and there's no risk. You just have to drink the Mucomist. It smells bad because it's a self-hydral. It smells like rotten eggs. It's certainly not something that should make you comfortable. You know, if you give someone Mucomist, they can still get radio contrast-induced kidney injury. Calcium channel blockers, I probably wouldn't put someone on them if they're not already on them to try and prevent radio contrast injury. But if someone's already on a calcium channel blocker, I think you should continue it. We frequently are called to ask whether or not we should dialyze someone after they get IV contrast. It's of no benefit, and it's invasive, and it doesn't help. Theophylline is actually of modest benefit. It has not become popular in the United States because I think people aren't very comfortable with theophylline. Theophylline is a xanthine oxidase inhibitor that 30 years ago was used quite commonly in people with asthma and COPD. It's fallen from favor because it can be toxic at high levels. And so most people have no experience using theophylline. So I don't think people are very comfortable with it. So it hasn't become commonly used, although there are studies that suggest it's a benefit. Phenoldiprem is a dopamine DA1 inhibitor. Dopamine at low doses stimulates DA1 receptors that are vasodilatory in the kidney. At higher doses, dopamine is a vasoconstrictor. Phenoldiprem is an analog of dopamine that binds exclusively to DA1 receptors. And it's actually marketed as an IV antihypertensive agent. There was a lot of enthusiasm about whether or not phenoldiprem would prevent radio contrast-induced injury. The pathophysiology of radio contrast, if you talk to someone who's had radio contrast, they get a flushing sensation because they vasodilate, and that's followed by a vasoconstrictor response, especially in the kidney. And it's this vasoconstrictor response in the kidney that's thought to be damaging and generates free radicals. That's why Mucomist is thought to be a benefit. Phenoldiprem was hoped to be a benefit because it would oppose this vasoconstrictor response in the kidney. Unfortunately, randomized trials have not shown it's of a benefit. In terms of differential diagnosis, there are others. Probably the main thing that you might see in someone who gets IV contrast, if it's an arterial study such as a left heart cath, you might see atherosclerotic disease. You wouldn't see that with venous contrast because you're not invading the arterial vasculature. But if someone has the arterial vasculature cannulated for some sort of arteriogram, you may see atherosclerotic disease. You may see embolic disease in the digits. You may see livedo-reticularis. If you catch it early enough, you may see eosinophilia and low complement levels. But frequently, atherosclerotic disease doesn't cause renal failure for days or weeks, and so you may miss the eosinophilia and low complement levels. And unfortunately, with atheroscleroemboli, these people frequently don't recover. And then when AKI occurs, how do we treat it? Well, if there's volume overload, we obviously restrict salt and water. We give diuretics, and if we can't control their volume status, we may resort to dialysis. Hyponatremia can occur because of the kidney's impaired ability to excrete free water. You restrict water both enterally as well as intravenously. Hyperkalemia can occur. We restrict potassium, and we give things that may bind potassium, such as K-oxalate and newer agents. And if hyperkalemia is uncontrollable, we resort to dialysis. Acidosis is common because of the kidney's ability to excrete acid. We give sodium bicarbonate either orally or IV. If you're giving someone parenteral nutrition, you can replace chloride with acetate, and if their liver works well, they'll metabolize the acetate to bicarb. And if acidosis is uncontrolled, we resort to dialysis. Hyperphosphatemia occurs. We restrict dietary phosphate and give phosphate binders. Sometimes people's calcium will fall. If they become symptomatic, we'll obviously supplement their calcium. Hypermagnesemia can occur and is usually preventable if you avoid magnesium-containing medication. And then nutrition is a big issue. You want to make sure these people get adequate calories. Protein restriction's a double-edged sword. You can decrease generation of azotemic toxins by limiting protein, but if you limit protein too much, you may impair recovery and healing. So mild protein restriction is probably reasonable. And then I mentioned dialysis. The indications for dialysis are what you see here: uncontrollable volume overload, uncontrollable hyperkalemia, uncontrollable acidosis, and impending uremia. And I would emphasize that uremia is not simply elevated urea nitrogen in the blood. Urea is not a uremic toxin. Elevated urea is azotemia. Uremia is kind of an unfortunate term. Uremia is a clinical syndrome. It's probably caused by toxins that we can't measure very easily. And you'll see, lethargy, confusion. You may see seizures, and you may see inflammation of internal organs, such as pericarditis, sometimes peritonitis. And we obviously want to avoid uremia. These are the classical reasons why we turn to dialysis. Dialysis typically simplifies dietary and fluid management. What's the prognosis of acute kidney injury? It depends a little bit upon what the clinical situation is. In a young, healthy woman who develops acute kidney injury following childbirth, they'll typically recover. A small percentage of the patients may get so sick and not survive, but that's relatively uncommon. Probably a third of patients with nephrotoxic AKI will succumb. And if you have acute kidney injury after major trauma or major surgery, your mortality is quite high. At least in the United States, you typically don't die from your kidney failure. We can dialyze just about anybody. When they're particularly unstable, we may turn to more continuous types of dialysis. We don't have time today to talk about dialysis in detail, but there are a variety of ways we can dialyze people. Most people don't die because of their kidney failure. They die because of an infection or because of whatever their primary disease process. Of the patients that don't die, probably, about 15 to 20% will have nearly complete recovery. About 5% won't recover at all and will remain dialysis dependent. About a third will have incomplete recovery. Of those people, a significant proportion will have stable but impaired kidney function. But some of those people with incomplete recovery will ultimately have functional regression because of hyperfiltration injury. So that's acute kidney injury as an overview. I thank each of you for paying attention. And once again, I apologize for missing the message about the change in the time zone. My plan is to talk about my favorite disease, cystic kidney diseases, next week, and I will make an effort to get up earlier. Unfortunately, I'm not a surgeon, so I'm not usually up at 6 o'clock in the morning, but we'll make it next week. Anyway, thanks for your attention. I wish you luck. I'll be happy to answer any questions.
Yes, thank you for your lecture. Yes, and we already have questions. Can you give some details on diuretic usage in acute kidney injury patient with severe kidney failure, and also about infusion therapy with acute kidney injury with volume depletion, how to treat? Yes, it's was and me my questions too, and if it's possible, explain us what do you mean aggressive dehydration?
All right, so let me take those one at a time, and I might have you repeat them. The first question had to do with diuretics in acute kidney injury. Usually the diuretics we turn to are loop diuretics because they're more potent. Occasionally we will combine loop diuretics with a potent thiazide such as metolazone. They can be helpful in terms of avoiding volume depletion. They will tend to increase excretion of certain electrolytes, particularly potassium. Probably the one caveat is if you use diuretics in someone with acute kidney injury, you want to make sure that you don't induce volume depletion. We typically use them in people that are volume overloaded or at least have normal intravascular volume. And sometimes they just don't work. They typically will not improve glomerular filtration much because obviously what they're doing is they're decreasing absorption of electrolytes by the tubules. They don't really affect glomerular function much, so they typically don't really improve GFR. Now, what were your second questions? I'm sorry.
Second question was about infusion therapy.
What what kind of therapy? I'm sorry.
If you infusion therapy, infusion. Fluid therapy.
Oh, fluid therapy. Oh, oh yeah. I mean, in someone who's volume depleted, absolutely, fluid therapy is critical. I mean, if you see someone who's volume depleted, the first thing you should do is give them intravenous fluid. Now, you have to assess someone's volume status before you do that. If you see someone who's oliguric, it may be because they're volume depleted, or they may have congestive heart failure or chronic liver disease or some other reason. And so by giving someone like that fluid, you may make it worse. But absolutely, if you can convince yourself that someone is volume depleted, the first thing you should do is give them volume. Now, what you use for intravenous fluid may depend upon what their electrolytes look like. If their electrolytes aren't terribly disturbed, you may simply give them saline or what are called balanced solution. Lactated ringer is probably available in Ukraine, I would guess. It's a mixture of several different electrolytes, including lactate and a little bit of potassium. If one of the things we will frequently see in people with acute renal failure, even when they're volume depleted, is they may be acidotic. They may have a low serum bicarbonate and a low pH. And in that case, rather than giving them saline or lactated ringers, you may want to give them IV fluids with sodium bicarbonate, something like D5W with 150 milliequivalents of sodium bicarbonate per liter, which is isotonic and similar to saline, but has bicarbonate. And so what you use to resuscitate someone who's volume depleted may depend upon what their electrolytes look like. And then I think you had a third question.
Thank you. But student not understand doses of, for example, infusion therapy for a patient with acute kidney injury, and what is the control methods for infusion, for doses in infusion fluid therapy. And same question about doses for diuretics.
I'm not sure I'm understanding your question. When you say infusion therapy, are you suggesting fluids plus diuretics?
No, it's separate questions about dosage for diuretics and about fluid therapy. How we can calculate amount of liquid for patients.
Calculate how much Lasix to give? Is that your question?
Calculation amount of liquid for patient with acute kidney injury. What is your recommendation?
You mean how much fluid to give them?
Yeah.
It would depend very much upon what you think their volume status is. If they're volume depleted, we may be fairly aggressive, especially early on. If you see someone who has acute kidney injury, who's clearly volume depleted and hypotensive, you may give them a liter of fluid over an hour or two. If someone's not volume depleted, and they have acute kidney injury, how much fluid you give them probably depends in part upon how much urine they're making. If they're making absolutely positively no urine at all, their insensible losses, if they're not on a ventilator, are probably somewhere around a liter a day. And so just to keep them from being volume depleted, they'd probably need about a liter of fluid. Now, that includes everything they're ingesting as well as what they're getting intravenously. If someone's on a ventilator, that decreases their insensible losses. Their insensible losses are probably typically more like about 500 milliliters per day. Typically, in someone with oliguric acute renal failure who's not volume depleted, we have more trouble with volume overload than volume depletion. In other words, these people are frequently getting more fluid for a variety of reasons because of antibiotics and vasopressors and nutrition. And usually we have more trouble with volume overload as opposed to volume depletion in those patients. So we typically are trying to limit the amount of fluid we give people with acute kidney injury unless we think they're volume depleted.
Okay, thank you. Questions, colleagues? Do you have questions?
Can I ask a question, please?
Sure.
Dr. Coley, my question is not about acute kidney injury itself, but about nephrological problems in general. How often do you use kidney biopsy in your practice? How often is it necessary to do it?
It depends upon how you want to measure how often. We are in a fairly large referral center. In the United States, there are what are called trauma centers that are of different categories. We're of the highest category trauma center. We're the only level 1 trauma center in the state of Oklahoma, so we get a lot of trauma, and we get referrals into our medical center for a variety of other reasons. And so we probably are doing a kidney biopsy at least once a week. You know, in general, with sort of a general nephrology practice, I wouldn't say it's uncommon, but we're obviously reserving kidney biopsies for people that we think have some sort of disease that we can effectively treat. And what I mean by that, a kidney biopsy is invasive. And obviously one of the major risks is that people can bleed. You're putting a needle where it doesn't really belong. The kidneys get about 20% of your blood flow. They're very vascular. So we don't do a kidney biopsy, you know, unless we have a good reason. And we think it will change our therapy. If even if we're not sure why someone has kidney disease, if they have, for example, small kidneys that are quite echogenic, suggesting that they have chronic kidney damage, we probably would not biopsy those kidneys because we wouldn't be able to change their kidney function because it's chronic. We biopsy patients if we see something that suggests, you know, some sort of disease process that we think we can effectively treat.
Okay.
Glomerulonephritis, it's, you know, occasionally interstitial nephritis, you know, some sort of vasculitis. It's very unusual that we'll biopsy someone that we think has ATN. Occasionally we will biopsy a kidney and we don't know why someone has kidney failure, and we'll see ATN. But if we have a clinical situation that's a common cause for ATN, we typically don't biopsy those kidneys. It's typically one of the other causes.
Thank you very much. Thank you.
Thank you. Maybe more questions? Today maybe any additional questions. It was so interesting, yes, and I think we continue our discussion and question next time.
Well, if you guys think of questions, feel free to email me, and if you think of questions, we can try and address them next week. Once again, I'm sorry I missed the memo about the change in the time zone. I appreciate those of you who hung around, and I wish you luck in the war.
Thank you, no problem. And we wait you next lecture on next week, yes, and wait this time. And we meet at 7 o'clock on your time and 3
Yes,
o'clock on our
absolutely,
time. Okay.
absolutely. Next week,
Thank
7 o'clock our time.
Okay, thank you. Thank you.
Thank you.
Thank you.
Thank
Good
you
luck
very
to you. Thanks for your attention.
Thank you. Bye.
much. Bye.